There we go. Couple little logistics. All right. All right, I would like to welcome everybody to our live chat today with Dr. Sheryl Lewin. It is on porous implant ear reconstruction risks. And she is going to go over today some of the different things that could potentially happen with surgery so that we as parents, myself included, are always in the know. Dr. Lewin?
Thank you very much, Tiffany, and thank you to everybody who's joined us. Okay, first I have to tell you, I'm not very savvy with social media, otherwise, hence Tiffany helps me with all this stuff. So yesterday she's like, you need to go to Best Buy and get a ring light so you know your face looks pretty and all this. And I'm like, what on earth is a ring light? And then of course I go to Best Buy and there's like just people in the parking lot going, how can we help you? You can't go in. And of course they're sold out of these ring lights. I have no idea. So I improvised today, so I'm going to show you what I did. This is our OR. Those are my OR lights. I see Kathy shaking her head. But, you know, it was a way to get a little light on the subject. But we love our Cove OR. It's beautiful here. So anyways, we're going to get on with our talk here about risks. I'm going to try to share my screen, Tiff.
Yep.
Okay, good. Okay, here we go. I'm gonna just make a little adjustment, sorry. Okay, I think we're good now. So today we're gonna talk about the risks of porous implant ear reconstruction. And for me, I always try to think of my talks or my conferences or even the website, always from the perspective of if I were a parent who had a child with microtia. And I wanna always have that in the back of my mind, like, what would I most wanna know? And since I have, you know, my insight is into the particulars of this surgery, I wanna make sure that a parent really understands not just the pros that are really fun to talk about, but also the cons, because when you're trying to make this decision, should I have an ear reconstruction, which type, etc. I mean, the pros everybody kind of knows about, but the cons is where you need to kind of do your hard research and work on deciding what you want to do for your child or yourself. So today we're really going to focus on those which come in the form of a few different things, like risk. We'll define it as the chance of having an injury. And complication is basically a secondary disease that develops in the setting of a primary disease. So we do an ear reconstruction, and then we have an issue afterwards that's a complication such as an infection or a bleed. So that's what we're really gonna talk about. But there's one other thing a parent really needs to understand, which is the concept of informed consent. This is a legal binding thing that a surgeon needs to give a parent. Now it's typically given in the form of a conversation, but that conversation is meant for a patient to consent to surgery after they get a complete, full understanding of what is involved. So that involves the discussion of these risks and complications. So there's a very general basic rule of surgery that is not very surprising, but the more experience you have, the better the outcome typically is and the fewer complications that you will have. But when it comes to PIER surgery, I will say that the experience is particularly critical. So if you look at a graph and you're basically looking at the outcome of surgery on the vertical scale, you know, with the very top being like a 10 out of 10 ear, and then experience on the bottom over time, then I feel like you would get a curve a little bit like this. And what that is basically shows you that for me, after about 500 ears, you know, this is a very steep learning curve. So I feel like, you know, every 100 ears, I would get better at my outcomes. Now at a little over 1,000 ears that I've done in my career, so the last 15 years, I feel like I'm, you know, on the more flattened part of the curve. Oh, to use a term we're all very familiar with. And then, you know, if we go and look at the rest of this graph, you can see there's a point where things start to taper off a little bit. And, you know, at that point, I feel like you're at the top of your game and it's time to retire because you're too old and you're starting to make mistakes. So that'll be another 15 years from now for me, I hope. So if we look at the same idea on this graph, but we're looking at the rate of complications, it's sort of an upside down of the same thing. So early on in your experience, you'll have your most complications, and then later, those complications probably level off. Well, that's really, really important because when you're looking for a surgeon, you really want to find somebody whose complications are kind of at that leveling off point. Uh-oh, I hit a problem. I'm gonna have to escape. I'm so sorry for 1 sec.
Did you freeze up?
Yeah. Like completely.
Do you want to just stop sharing screen and then try again?
My mouse isn't working. Oh goodness, that hasn't happened. Oh, I can use this. I'm gonna stop sharing for a sec. I don't know.
The joys of live presentations.
Okay, I'm gonna change my view to see if I can get this a little easier. And I'm gonna try and share screen again and see if that works.
There you go.
Let's see if it works this time.
Looks good.
Okay. Okay, we made it to the next slide. So this is, you know, fairly obvious that all surgeries have risk, but it's sort of on a continuum, and there's expected risk and then not expected risk. So on the expected side, these are going to be more common things, and they're often less significant. The not expected things are rare and they're more significant, and they definitely have consequences that you need to be aware of. So we're going to be focusing more on that right side of this arrow. So here's an example of expected risks that we would see almost with any surgery. You get swelling, bruising, scarring. You can get minor fluid collection, wound healing issues. But specific to PIER surgery, the cup can sometimes cause a little pressure when it's protecting the ear, and you can get some temporary hair loss there. Very rarely is it permanent, but you can get it temporarily. And then temporary numbness, like the ear and the scalp will both be numb right after surgery, and then over months of time, they gain sensation back. So the great thing about these expected risks is they typically all resolve on their own. This is the focus of our talk today, the risks that we don't expect and that have a more significant consequence. So exposure, fracture, infection, bleeding, nerve injury, vascular injury, and finally failure. So the big issue with these, oh goodness, it did it again, Tiff.
It's okay.
It's my mouse is unable to.
Can you use your like trackpad?
Yeah, no, it's not working. Okay, I'm gonna try this one more time. I'll just try and be very careful.
Okay.
Goodness, that's gonna make for a rough talk today.
Well, thank goodness you have your beautiful lighting on when we get to just stare at your face.
Yes. Not happy about that, let me tell you. Okay, let's try.
Good, you're good.
I'm gonna have to be so gentle here. Okay, I'm only gonna use this tab. Okay, so these not expected risks do not resolve on their own. That's why they're particularly important. So one question very, very commonly asked of me is, what is the risk of implant rejection? And it is 0%. And I'll explain why that sounds confusing, but you have to understand that there is a real clinical definition of rejection, and it's to have an immunologic reaction against a transplanted organ or some other human tissue. So that's something you see with a kidney transplant, but you cannot see rejection with any type of synthetic implant. So why is that? Well, the body only rejects living tissue, and the porous polyethylene, obviously not living, is very special. Like the pores, the little tiny holes, make it something that we call biocompatible and inert. So biocompatible is kind of obvious. It likes being inside of a body. But inert is something like the FDA has determined that this material is the least reactive in the body. So that's why it's been literally used in the body for so many decades, because the body just accepts it, and that accepting of it is called tissue integration. And it's just a picture that shows you, you know, with a microscope, you can actually see tissue growing inside of the implant. Tiffany wouldn't let me play this video, but I have a video where we have an implant that needed to be removed, and I cut into the middle of the implant, and you look, and the implant itself is bleeding. So that's sort of proof positive that the tissue is integrating. So when people say rejection, when they're talking about porous implants, what they really mean is actually exposure. And that's obviously different. Dictionary definition is the state of being exposed, but an implant exposure is basically a hole, and you can see part of this porous polyethylene implant. It's visible. Now, you get a hole in the body's trying its best to heal it. And so often you might not see the actual implant, but like in this fourth picture, you sort of see the scab of the body trying really hard to heal it. But sometimes, you know, if the exposure is too big, your body will not be able to heal it. So why does this occur? My belief is that it has very little to do with the implant, and it's all about the covering of the implant, what we call the living membrane TPF flap. TPF is just an acronym for a long word, temporoparietal fascial, and that's the flap that sits above your ear, and we use for almost all of these ear reconstructions. So I want to just take you through how do we treat this when it occurs. And when we know that it's not going to heal on its own, we can show you a close-up picture of that, you know, tannish material is the implant itself. You can see the hole that we need to fix. Now, it seems so small and tiny, but you cannot just throw a couple stitches in there and think that it's going to heal. It's actually kind of a technically challenging solution. And, you know, I like technically challenging things. So for me, it's not fun at all to get an exposure, but it's fun to try to fix this in a way that looks just as beautiful as the ear looked before. So in this child, we took her to surgery, and this was our coverage of the implant. You have to clean really well, and then you cover with healthy tissue and cover with skin. And then you can see here, 4 years later, kind of hard to see where the exposure really was, or where those new suture lines were. And so to me, that's the elegance that I'm striving for in these ear reconstructions. If you are unfortunate enough to have an implant exposure, I want you to have just as beautiful or even more beautiful of an ear afterwards, because it's an opportunity to do a little nipping and tucking at the same time if we want to as well. Here's another example of an implant exposure, and this is one of those ones that has a scab. I'm dying here. Oh gosh, you guys, I'm so sorry. I don't know a way around this problem except for stepping. Oh, okay, I fixed it. Goodness, it's gonna torture me all day. Okay, so here's the scab on this implant exposure, and when we were in the operating room and we removed this, you can see the actual implant of the helical rim. Do our cleaning, and in this case, we had to bring tissue from just above the ear, flap it over the helical rim, and then put a new piece of skin on there. And so here is what that patient looks like a year and a half later. So I want to also underscore the importance of wound care, because typically these things don't happen till you're back home. And what we've discovered in the last couple of years is if we're very good with wound care and you follow this very precise regimen that we tell you, and it's personalized to every individual patient, but we literally talk every 2, 3, 5, 7 days, to get you comfortable with the wound care, we can often make great strides with this. So here's an example of a patient who had an exposure. You can see in that first picture on the left. And then just with wound care alone, they were able to heal this wound. And that's because of that porous nature of these implants and the fact that tissue grows into them, so you could still help them heal if you baby them just right. So here's an ear where you can see this white area above her earlobe, and if you show this to any plastic surgeon, they would say that skin is dead and it's gonna go on to, you know, completely die and come off, and you'll be looking at the implant. And there's very little one could typically do to heal this. But this is why I'm saying don't count out wound care. If you are meticulous and you follow our instructions to a T, this child was able to have absolutely no surgery between these two pictures, just wound care. So that's why we're big believers, and a lot of what we talk to you about is, you know, we're very obsessive with that component.
Hey, Dr. Lewin, I have a couple questions in chat about exposure specifically.
Okay.
One, this is from Christina. What is the time frame of the risk of the implant exposure? Also, like, how long after post-op are you in the clear for an exposure?
Okay, excellent question. So typically an exposure is going to occur in the first 2 months after surgery. So that's when I'm making you guys, we're on this wound care regimen. No, even if you don't have a threatened exposure or anything, we're still on this very particular regimen. And then what we do is you pretty much are out of the woods for what we call an early exposure. There is some risk, albeit small, for what we call a late exposure. And a late exposure would be some injury occurred, or some infection, or some problem, or whatever it might be. And so, you know, it's probably fair to say you're never forever out of the woods, but the late infections are very, very, very rare.
Another question too. So some you need to go back to surgery, some can be treated with, you know, medicines or the different procedure you use. How common would you say is with an exposure you have to return to surgery?
Oh, thing is, a lot of times we jump on it so early, they're not quite getting to actually being exposed. So that's a really tricky one. I feel like, you know, probably we've, you know, if you have an exposure that's present and not healed after a month, let's say, you're coming back to surgery. But what those numbers are, that's actually one thing. It's a good question, but I don't want to mislead anybody. I don't know the answer of that, actually.
Okay, that's it. Thanks.
Okay. Okay, so we're going to switch gears from exposure to fracture. And I have learned a lot about this, particularly in the last year, so I'm excited to share it with you. But this is an example of a two-piece implant that has a rim here and a base, and then you have to melt these two together and you get this completed two-piece implant that you see on the right side. And there's different sort of brands. You can get it in Medport or Supor, there's some others. But we use this for, you know, well over a decade, was very happy with it. And then there are some issues I had with this implant. That's what led me to switch to other things, but fracture was the biggest one. And what I came to recognize is that whenever you're joining two parts together, there's going to be some risk that those areas can either come apart or break. If they just came apart, it is just a matter of time until they break. We call that a fancy term, subluxation. And then just the mechanics of the wear and tear on an ear are such that eventually you will get a fracture. But I've learned a lot about fractures over the year. And so I want to tell you a little bit about what I'm calling the progression of a fracture. So here's, you know, it's always the rim. It's not the base that has a problem. It's always this thin rim. So this ear has a canal, and I don't know how long after surgery, but it's a healthy appearing ear shortly after surgery, let's say. And we have noticed more fractures, a higher rate of them occurring in patients that have canals. So this patient did well for a very long time and then sent us this picture from home on a follow-up. And this is subtle, but there's like a slight bend or angle in that rim. That's never normal. And it doesn't, the ear still looks okay, but if you just wait over time, the difference between these two pictures was several months before the patient was getting onto the operating room schedule to have this two-piece implant removed and replaced. But I just want people to understand that this is what fractures used to look like in my practice. They were very obvious, and patients called and they're distressed because the ear looks very different. However, when maybe around 2013 or thereabouts, I started strengthening these implants and putting more of the porous polyethylene in there to make them stronger. And what I realized that resulted from those, quote, stronger implants is now a much more subtle form of fracture. I don't see as many of those like impressive fractures as I see these that, the ear still looks pretty good. It hasn't, quote, fallen apart. So what that tells me is I believe there's probably many more undiagnosed implant fractures out there, and maybe they are staying fairly stable for a longer period of time, so we don't necessarily know about them. But what we've taken to doing is asking for follow-up more, from our patients. We would like patients to send a picture every year. I say every year on your birthday, send me a picture of the ear and we can just take a look at it. And just on some random ones, we've noticed these subtle changes. So I want to talk to you about, sort of the most exciting news is that with these 3D, we call them Lewin ear implants by Supor, we basically don't have fracture risks anymore. And that's, I don't want to say 100% because so far we're at 100% of no fractures, but I don't know exactly what the future holds. But if you sat there and you held these two implants in your very own hands, you can tell why the one that's two pieces would more likely fracture, albeit it's strong, but would more likely fracture than these. They're just formed as a single unit and incredibly strong. So here I just want to take you through a patient. Here's 2 months after surgery. You can see that nice, almost too perfectly round rim. And then here's the patient who has this fracture of their rim. And on this angle, you could miss it, I think. But when you turn just so and you have the light cast, I think it's obvious here that there is a subtle crack in that rim. And the concern is, it's not emergent, it's not super urgent, but over time, the fact that there's that rough edge and it's kind of, wear and tear on the tissue above it, I'd be worried that it could lead to an exposure. And so we don't, we take it seriously and we recommend removing and replacing the implant. So we did that in this child's case, and you can see this is red because tissue is clearly integrated into this implant, but there's this subtle fracture. It looks exactly like the second picture, exactly. So yes, we have a problem, but now what we can do is we can replace with a 3D ear. So this is the child's opposite ear. We had it scanned, actually, this patient, I believe, had it scanned in New York, so didn't even have to come here for the scan. And then we went ahead and created a, essentially mimicked a mirror image of this ear. Now what's so cool is we can put in this new implant. This is an early post-op, so the ear still looks kind of bruised and swollen, but I didn't have any other pictures to show you. But what we're able to do with this patient is we just use the envelope of that skin and fascia, and it's completely covers the new implant. Occasionally we use a small skin graft for the back, but in this child's case, I believe you can't even see a scar because the scar's behind the ear. So all that you're seeing is just kind of tissue healing, and he's got a new ear that looks like his other ear. There's another child who had grade 3 microtia, and here he is, several months or whatnot after his first surgery. So he had one operation, and you can see he's got, you know, a nice ear that sticks out. And then here he is, and the ear still looks nice, but it's not quite sticking out as much. And so we had good symmetry at 1.5 years after surgery. But here at 3.5 years after surgery, you can see what happens with the fractures when they lose that structural stability. They fall to the head. So they just can't support standing out anymore. And so this child also got a 3D scan of his healthy opposite ear. And then you can see the little fracture that he has in 2 or 3 little spots there. And they're minor fractures, but enough to make a change. And his new implant. And so these are right before he went into the operating room with the old 2-piece implant. And here he is a couple months out with his 3D implant. And so what you can see here is, you know, we now have an ability to really make an ear very, very, very symmetric. We can pay attention not just to the front of the ear looking beautiful and just like the opposite side, but even the back of the ear. Here's a little boy. He wears his hair super short. I mean, people stare at the back of your ear if it looks different. So nobody really talks about wanting the back of the ear to look beautiful, but I want the back of your ear to look beautiful because I don't want anybody even staring at the back of your ear. So our goal is, you know, as perfect a symmetry as possible.
Dr. Lewin, I have a question from Sala. Do the fractures occur because of accidents or because there's a failure of the implant?
Okay, great question. And both is the answer. So definitely I've had kids like crash and fall, hitting concrete, got a scrape and fractured at the same time, or super hard elbow to the ear, or some other significant trauma, and they knew the ear was fractured. Kid felt pain and the implant was fractured. I feel like almost more often parents tell me, I have no idea what happened. Like, I just, you know, I think it's this concept of a microfracture and a subtle fracture at the beginning. So you don't see an obvious fracture, and so you don't know when it occurred. And then just wear and tear, sleeping on the ear, whatever it is, like normal stuff will eventually make that ear kind of go towards the head, not look quite as symmetric as it did earlier. And then you know there's something going on. Does that cover it? Are you there, Tiff?
I'm talking on mute. This is my husband.
Did I lose everybody, or
anyways, yes, we're good. Thank you.
Now we're going to switch gears to infection. And there's this concept amongst surgeons that do not do this operation that infections lead to loss of the ear reconstruction, and they're not treatable. And that is just absolutely not the case. I have had many years ago, one patient who had a crazy infection with a very atypical bug, not a typical bacteria. And that child, we didn't have a proper medication to treat that very odd organism. But apart from that one child, we've been able to treat these kids, and usually just with an oral antibiotic, which is wonderful. And the reason that works is because of this flap, this magical flap that's like the whole game for these ears. It can bring these antibiotics to your ear. So this is a child on the day of surgery, and she had basically what we call kind of like a superficial infection. Like the infection didn't start on the inside of the ear. It actually is, like, you can see it's on her cheek and her neck and all around her scalp. And it's pretty crazy looking and very, you know, I'm sure it was tender to her as well. So we started her on medication at that time. And after 1 week, able to get her all cleared up. So it's very, you know, nice that she's very stable 10 months later on this exam. Here's another child on the day of surgery, and then 10 days out, this ear is really swollen and it's what I call stressed out. The skin is unhappy. It's starting to be open wounds. You can see some yellow in there. It's not a happy ear. So we went ahead and started our antibiotics for this patient. And 1 month later, you know, healing much nicer. And then 5 months later, very hard to tell there was any issue at all. So that's the important take home point is, you know, we have ways to deal with these complications when they occur, and, you know, we just have to unfortunately go through the process of it, but with treatment, they can often do very well. So we're gonna move to bleeding, obviously a risk with any operation. This is a cutie pie who's from Colombia, actually, and he came to me, and the ear part of his surgery was the easy part. I wouldn't say it was the easy part, but he is a very rambunctious 4-year-old. So 2 weeks after surgery, which is late for bleeding, we see an abdomen that looks like that. So 4 years old, and you're probably thinking like, oh my goodness, what are you gonna do? He's gonna have to go back to the operating room. And no, none of that occurred. I remember this was 2 days after Christmas. Nobody was around, it was late at night. I took my sister with me, and between the parents and my sister and I, we distracted this kid with singing and a towel so he couldn't see what I was doing. And that tummy is completely numb because we've already, you know, dissected above there. So we can just pull off that fluid very easily. He never knew what happened. No, I mean, anesthesia required. So it doesn't look awesome, but there's ways that we can deal with it, and it doesn't end up being a huge deal. So I just think that's important to know.
Doctor, let me go back to how you were treating some of these issues with antibiotics. Christine had a question. How long, what's the average length of being on an antibiotic?
I usually give them for 2 weeks so you have it, but it may only be 1 week or 10 days that you're on it.
Okay, thank you.
We're going to switch gears to nerve injury, and I think this is a very commonly misunderstood complication. And maybe it's sort of because they talk about nerve injury with atresia repair, and they are not at all the same nerve injury. The nerve injury with atresia repair is the entire facial nerve. Half of your face would be, you know, basically paralyzed if that were injured in that surgery. We are nowhere near the branch, you know, the main branch of the facial nerve. So the main branch is what you see on the far left of your screen. That light blue stump is the main branch. And you can see it's sending little branches to the chin, the lower lip, the upper lip, the cheek. And then the one that the white arrow is pointing to is the eyebrow. That's the one that can get injured when we're harvesting the flap or taking that flap up. And often we can avoid that injury because in the operating room, I have someone on the other end of where I'm dissecting telling me, twitch, twitch, twitch. And that means like you're getting close to that nerve. And then if we're too close, we can alter the pattern of how we take the flap, leave that area alone, and go on and do the rest of our surgery. But let's say for whatever reason, there wasn't a twitch or we weren't aware and we injured this nerve. It actually, we call it arborizing. It turns into like a huge tree of branches to move your upper eyebrow, to move your eyebrow upward. And so most often, even if there's an injury and you can't move your eyebrow after surgery, within 1 week or 2 weeks, you're back to normal. But sometimes it takes actually 6 months to be back to normal. So even those patients, we don't call that a complication because yes, the nerve got injured in that, it was swollen and unhappy, but it recovered. So it isn't a permanent nerve injury. It's just obviously a temporary one. So we only really look at the permanent nerve injuries, and those are very, very rare in my practice. So we talked about avoiding the injury, and it doesn't affect lowering the eyebrow. You can frown and put your eyebrows down, but if you actively try to raise your eyebrows, only one goes up. The thing is, in normal communication, you're not really elevating your eyebrow that much. So it's kind of a hard thing to diagnose. So every time you come back, for a follow-up visit, we're always asking, raise your eyebrows, so we can track it ourselves. We talked about that. So if you don't like to see graphic surgical images, you can close your eyes on this part because there's going to be a picture of a flap. And the reason we have that is to demonstrate that there's blood vessels here, arteries and veins, and they're running through this flap. The arrow points to what we call the pedicle or the base or the beginning of this blood supply. And if there were an injury or a cut to that area, that would be very, very bad. I hesitated putting this in because I'm like a little superstitious, but I have never cut that vessel. I am very slow and cautious at this part of the surgery. Everybody has to be quiet. All music is turned off. We are super focused. And I believe, you know, that's enough to keep you out of trouble. But if I were to cut this, there is a way to repair this vessel with microsurgical techniques and get this flap to live again. If that repair did not work, then you would have basically a problem that you wouldn't be able to save the ear. That would be a big risk for failure if you couldn't get these vessels back together functioning. So failure of a flap, this, you know, in my world of microtia reconstruction, this is sort of the worst thing that happens. You know, people are generally healthy patients, but, you know, failure in this is obviously, you know, a very painful thing for me, as obviously a much more painful thing for the patient that it might happen to. I'm very blessed and feel grateful that this is a minuscule risk in my patient population, but this is a lovely patient, wonderful family, and we don't know why her flap failed. But you can see, you know, she had almost anotia. She did have trickier anatomy than some others, but I didn't perceive anything at that middle picture being particularly abnormal. But basically her flap just didn't have, it just kind of got too thin. Like I was looking at it going, oh my God, that looks awesome for just 1 week. But normally they're much thicker because they're swollen. And in her case, it just never had a thick swollen area and it just kind of withered away. So unfortunately, we came to the conclusion, you know, there wasn't a way to save this ear, and you would basically have to remove what you see, remove the implant, remove any unhealthy tissue, leave the healthy tissue behind, and basically start over. And we would wait a certain period of time to start over. This family did not want to continue with ear reconstruction because we had, you know, exhausted, you know, our options, trying very hard to save her ear.
Hey, Dr. Lewin, can you, we just have another question here. Can you just quickly again talk about what that flap actually is? Is it part of the implant, was the question?
Okay, so no, the implant is, you know, sort of created sterilely, comes to the OR, and I refine that and we put it into position. The way that these ears are healthy and last a lifetime and act like your other ear is because they're covered with healthy tissue. And so the tissue we use is called a TPF flap, and it's a type of fascia. Fascia being the covering that's on all of our muscles. So your thigh muscle has a fascia, and your, you know, forearm has a fascia. This is the fascia over, you know, kind of the area of your temple. So it's temporoparietal fascia. That has the picture that I warned people on was graphic, you know, has these not just arteries and veins, but it has nerves, you know, coursing through it as well as lymphatics and everything. So that flap, if it's healthy and happy, then it can cover this implant and integrate into it. And it basically tricks the body into thinking this implant is part of your own body. Hopefully that answers it.
Yes, thank you.
Okay. So there is a concept I think parents need to understand called a complication rate. And you wouldn't necessarily know exactly what that means or how it has to be calculated. But there's like, for it to be meaningful, it has to be calculated in a certain way. So it has to be your number for any one doctor. It's your number of complications that you've had divided by the number of ears that you have made. But the key is you can't pick and choose. It's all patients. And the only condition, that I put on that number is that they are all patients. I have to be the first surgeon to touch them. If they're coming to me, as many patients do from another surgeon, they have a different set of complication rates. And so I don't lump them all together. That's why when you see my complication rates, they're a portion of my practice, but they're not 100% of the ears I do. So they have to be counted consecutively. So every single person that had an issue is part of the count. And the key is that complication rates apply to the individual surgeon. They do not apply to the type of surgery. So somebody telling you, oh yeah, the rate of med-pore fracture is only 1% in the literature, that means nothing, actually. I mean, it just means nothing, because in the literature, there's so many variables and so many different things that don't make that so meaningful. So really what you need to know is whatever doctor you're looking to have do your child's surgery, you need their exact complication rates. Now, how are you going to get those? The truth is, I do not know. I really don't know anybody but myself that lists their exact complication rates and updates them every year. I mean, if you go back through all of my ERICLES conferences where we present this data every year after year, you can see my complication rates starting from patient 1, January 1st or whatnot of 2013. Every patient since then is in those numbers. And I make them public for parents to see. It's painful for me to remind myself that one little girl, her ear didn't work and I had to remove it. I don't like having to relive these complication rates, but it's important for a number of reasons from a parent's perspective, because every surgeon is going to have different complication rates, and it's information you would want to know. And I guess my take home would be, I think it should be required that people put this information out there, because Microtia surgery, be it rib cartilage or med-pore or PIER, they are prone to having complications, and they're particularly prone if you're not really experienced. But there's no reason that any doctor has to supply this for you. So I think it's just something you have to be an advocate for your child and ask for. So I will tell you, I was up until the wee hours of the morning last night, because giving these talks is what makes me do all of my complication rates. So I was kind of happy. These are fresh, hot off the press. We have not shown these to anybody because I literally finished them early this morning. But
shocker.
I'm a bit of a procrastinator on that. But basically, it's 7 years of my complication rates. And there's some, kind of nice, cool thing to point out. One is exposures went down from last year's complications, but fractures went significantly up. So if you look at these, last year I think I was 7.8 or something. So that just meant in this 2019 year, I had fewer exposures. So that rate went down a little bit. But for both years, the number of exposures with 3D and Lewin one-piece implants, so those are, Supor makes them, but there are specific design, is lower than my all-comers. So I don't know if that has something to do with the implant, because we don't melt it, so all of the pores are available for integrating, or is it because I'm more experienced in the last 3 years than I was in the previous 4 years, so maybe that has something to do with it. I'm not really sure. But the thing I am sure of is we have no fractures, and our fracture rate more than doubled. And so that's very concerning and significant. So I had basically, I count up all my kids, of those 455 kids, 30 kids across all those years had exposures, and 30 kids, it just happened to be this year, the same number, had fractures. And most of those fractures we unearthed, so to speak, recently. And so I feel like it's these subtle fractures that don't even look like fractures. Now, what the tiny bit of good news that has come out of it is that to help all those kids, every single one has gotten a 3D ear. So in a way, they ended up having a little bit of a benefit because they came and, you know, the fractured implant removed, the other one put in. So I think soon my fracture rate will start going down because I'm not doing those, I'm no longer using those two-piece implants. The one caveat to that is fracture of all these risks. You need to understand fracture is the only one that increases over time. So over your lifetime, your ear is subjected to more wear and tear. So those joints that we talk about between those two pieces more likely could separate or break. So it's still relatively a small number. 6.6 is not a big number, but those patients, all of them have to come back for surgery. So to be able to move that to 0 is a big victory for me, something I'm pretty proud of. In terms of infection, it's almost an identical rate, 1.7 versus 1.8. And in bleeding, also very close, 1.5. It's a little lower in all comers than the PIER one-piece ears. We have not had nerve injuries in these last few years with the one pieces, and only less than 1% on nerve injuries for all comers. No vascular injuries, and that one patient makes up my 0.002% here.
Dr. Lewin, we have a question from Christina. Is there a relation between age and risks?
That is a really good question. So I've thought about, like, just in my mind, but I haven't double checked it. So I don't think it's necessarily true, but I worry sometimes that exposure might be more likely in a younger kid, just simply because their flap is thinner. But my recollection is, it's not like all of our exposures. Those 30 patients are all over the map. We have old kids, little kids, and in the middle kids. So I could look and see, since I have all of their ages, I could look and see if there is, because it's a really good question, and Tiffany will remind me to get back on a little post about it. But it's just a thought. But the other flip side of that thought is the little ones have the nicest definition, and they look, you know, the most beautiful and realistic. So 4 is my favorite age to operate on, but I'll operate on any age.
That was a question. That was just a question that just popped up too. What is your ideal age for surgery?
Oh, good timing. I love the 4-year-olds. They have zero anxiety. Oh, we just did a 3D scan today on an upcoming surgery patient for the summer, and he was just turned 4, and like, it's just not a care in the world, super excited about his ear, no stress at all. We make surgery pretty fun, so that part's nice. When you get older, there's more stress, the flap is a little thicker, the definition may be a little less than it would have been when they were younger, but you can still get a beautiful ear. So my personal decision for what I like to operate on in terms of results, it's totally up to a family. You know, we can operate at any age. Okay, continuing on. So why am I so vigilant about tracking complications that I would be up till 2:30 in the morning getting those numbers to you? And I will tell you, it's because I absolutely think, much as we all hate to have complications, it is 100% what's made me a better surgeon. And it forces me to push the envelope and forces me to advance technology. It's those fractures I saw for the very first time in 2010 is what made me realize, like, we gotta do better than this. And then all the things that have come since then, and all the ways we kind of constantly change this in little ways every year. And if I didn't force myself to think about what is causing each and every tiny little complication that comes my way, then I don't think I could be, you know, the surgeon I am today. So I'm, in a strange way, thankful. I kind of think of it a little similar. You know how you tell your kids, like, you really do your learning from failures, you know, and from your mistakes, not from having success. And they don't buy it for a second, but we all know that, you know, as hard as they are, it is what helps you move forward and do better. So if you're a parent, you have to advocate for your kid. And I will tell you, a lot of the parents that come to see me have had to be very strong advocates because their insurance company wanted to tell them there's somebody right down the street who can take care of your kid and do this for you. And you need to basically prove to them that is not the case. So if you do go to your local surgeon, they need to give you this informed consent that we talked about, and that includes answering the questions. What are my risks? What are the benefits? What are the complications and the alternatives? So I think that knowing that that's one of your rights and you should not be leaving an appointment without getting all those questions answered is an important thing for you guys. When you walk in for your interview with your potential surgeon, don't be shy about asking these hard questions, because if you don't get answers you're comfortable with, that's your red flag to, turn around and go home. And if you get wonderful answers and you gel with this surgeon and you agree and understand where they're coming from, then that's your green flag. Like, this is probably going to work. But those questions have to include, how many of these have you done? Doing 1 a month, 12 a year, that is not enough, in my opinion. I think you have to have 100 under your belt before you're really going to be competent and qualified to get very reliable results. What are your complication rates? If they don't have them, that's a red flag in my mind. How many exposures have you successfully fixed? Exposures is the thing that if you don't know what you're doing, you take a sort of not good situation and you turn it into disaster. And then you make it so hard for anybody to be able to try and fix, because you went down this rabbit hole of the wrong decisions. How often do your patients need a second stage? So that number is decreasing every year in my practice, which is super exciting. That we're down to just one thing that I can't control and somewhat have to, tell a parent after surgery, like, I couldn't move the earlobe exactly where I wanted it. You may need a tiny earlobe thing, but that's really, we're really getting the hang of not having to come back for too many other things, unless you have, very challenging anatomy. Okay, here's the big one: before and after photos, not just of the ear that's operated on. You need to see what you are comparing this reconstructed ear to. And it is a huge pet peeve of mine that people hide their results. They don't show these ears from all angles, and they don't show close-ups. They don't show the scars. They never show the back. They just kind of avoid all the things that don't look ideal, and it's so unfair if you're a parent, because you just would never know. So I am all about transparency, and not just transparency of the pros, but transparency of those cons. So I don't know if cons is the right word, but the results and the outcomes, they're not always perfect. And a parent needs to see what am I going to really expect out of this surgery? And so I'm, out there with my results. You have 30 kids from every angle and rotating 360 degrees and up close so you can see everything. In addition to all those kids, all the posts that you have no control over, but everybody's posting, pictures of kids from all angles, which is awesome. And then, publishing your complication rates. I wish it was required and mandatory, because then parents would have something they could tell their insurance company: look, this doctor's complication rates are half of that doctor because she does this 3 times a week. Anyways, that's my 2 cents, my word about photos. This is my Facebook avatar.
You're so fancy.
That I didn't know how to make, so Tiffany had to make it for me. Yes, I'm just gonna plead my ignorance on it. But the thing about the photos is that what a parent doesn't know, that every surgeon that goes through a residency in plastic surgery, there are standard photos. We're all taught to take them. Every breast surgery has the same standard photos. And honestly, every website that does plastic surgeon does breast surgery, you can see every angle and you can compare symmetry, etc. Well, the same thing exists for ears, and I cannot find websites that are showing the true appearance of the ears. And I am very, judgy about it. I don't know why you would hide real results from parents, but I just call it, a red flag by this picture on the left side. You can make something look different than it is with lighting and tricks and whatever, but that's not the point. Show this ear from all angles and show how close it looks to the other ear. Okay, take home messages. We're almost done, you guys. The one and done mindset is something to talk about because this is not a normal ear. So even if surgery goes perfectly, your post-op goes perfectly, your healing is perfect, and your ear looks beautiful, it's still a reconstructed ear, and it doesn't act identical to the other ear. And you have to teach your children as they get older of the things they have to be careful about. I had an adult fall asleep in a sauna on her ear on hot wood, and she burned her ear. I don't know what the circumstances were that she would fall asleep in a sauna on her ear, but she literally had to come back and have, she developed a full thickness burn with an exposure. So, that you can't get away with anything you might have done if your ear was completely normal. So you should be vigilant about this. And some patients will have these complications that I've talked to you about. And the point is not to be devastated or think that, that can't be you. The point is that you choose someone who you trust is going to be able to get you through that complication, hold your hand the entire way, be there every step, so that on the other side of that, you still end up with a beautiful ear. We talked a bit that every surgery has these risks and that they are surgeon specific, and that experience is critical, and transparency, in my opinion, is absolutely key. So, ready to talk for questions.
All right. One question with Christina. Are the follow-up second stage surgeries as long as the initial surgery?
Oh no, they are not as long. They're, I usually book them for 4 hours because I don't see you until, the original one is 8 hours plus, 8 to 10. I don't see you till the day before, but sometimes it's 1 hour, sometimes it's 3, sometimes it's much more complicated, 6. So it just depends on what we're doing.
Great. Well, actually, we are out of our hour time. So much for your 20-minute PIER risk talk.
Sorry.
This is all really good information. And like you said, it's so critical from a parent's point of view to get this information, because it's hard to get, it's hard to understand. And the fact that you are so open about that is really great for parents to just, try to figure out. So we all do appreciate that. Oh, let me see this.
Thank you.
Can you speak to the risk of normal childhood activities, gymnastics, wearing helmets in baseball, etc.? This is from Carolyn. You can answer this, but also we do have, before you answer that, we do have a ton of live chats on our website. This was in post-op care. Some people had some questions on the porous implants. We had a porous implant live chat. So you might want to go through, because a lot of the questions might actually be in another live chat, and they are all fabulous. So I do suggest that you take some time to watch them. But Dr. Lewin, again, speak on the risk of normal childhood activities, gymnastics, wearing helmets, etc.
Okay, so the only activity we limit after this surgery is boxing, and that's because they don't have ear protection. But any other sport, we have athletes that have done everything, high school level, college and hockey. I have a college level volleyball player. Very physical, aggressive sports. The big risk with those is, as you can imagine, fracture more than any other risk. So I do think that, if you get a direct hit to one of these 2-piece implants, I think that is a risk, but generally speaking, given, the risk for all of those fractures is still only 6.6%, that's not a huge risk. So not enough to keep people out. I know that we do have this kind of cool thing. It's our private peer group. And what is so nice, it's really just kind of parents, honestly. I mean, Tiff keeps it going, but it's parents that like, they have a question, or, what helmet do I use? What sunglasses? How do you help me when my kid's ear, I can't get a mask to wear? Whatever it may be. I love that Facebook group because it's like no judgments. Everybody just wants to help people. So those kind of more specific questions, ask Tiff how to join the
I actually put the link right in chat.
Oh, good.
And that post-op care one was really good. I actually have these out from it. I still have these because I don't clean my office, but again, straight. But a lot of those live chats are good for that. But that Facebook private group, like she said, is really great because it's just the real scoop from parents. That's hard. Even, no offense, Dr. Lewin, but sometimes we know the real deals in and out versus the surgeon.
I know that's the case. I know.
So these are all great questions. Pardon?
That's why I'm calling you for help.
Exactly. So anyways, I hope you guys all found this helpful. Again, we do have a Q&A on Tuesday with Dr. Lewin, and we're going to address a whole bunch of variety of topics of questions that have been submitted, from the combined surgery to more of the flap to who knows what that we're going to be talking about then. So I hope you tune in. I think you all have the link to that. So again, Dr. Lewin, thank you. This will be recorded and posted to our website and social media. So thank you, everybody. Hope you enjoyed it today.
Thank you.
All right. Thank you. Bye.